Howard.
Okay, as you know, my name is Kelly Howard. I got my first chronic pain condition in about, sorry, apologies. There, okay, you know my name. I've been a chronic pain patient since 1978. When I got my first condition, I have since had numerous conditions piled on. My doctor first suggested I apply for disability in 1989. I continued working until 2011, most of that time as a medical research specialist, because I had a responsible doctor who responsibly prescribed pain medication that I took responsibly. I want to talk really fast, I guess, about the bibliography of this task force. Y'all use the word evidence a lot, but frankly, you are not paying attention to your own evidence. 3 of the main studies in your bibliography, the Scottish Guidelines for Chronic Pain, the NICE study, and the American Academy of Pain Insurance, Minimum Insurance Benefits, have 2 basic conclusions. One is opioids are safe and effective and appropriate for chronic pain treatment. The second is other therapies like acupuncture and such can provide some relief for some people and should be offered. You mentioned the SPACE study, and with all due respect to Dr. Darnell, it may be a good study in some respects, but as in reference to complex chronic pain conditions, it is a disaster. The only thing that it really proved is that the opioid group could be on opioids, those heroin pills, for a year. There was no addiction, no abuse, no misuse, no dose escalation, no overdose, and no deaths. So these demon pills didn't kill anybody in a year.
Thank you.
There are other problems with this study, mainly that the non-opioid group received opioid medication.
If you've got written comment, if you've got it written down, you can give it to Jason and we can circulate it.
Well, I did, but I had to do a whole lot of adjusting because my time got cut in half. So can I submit it later?
Sure.
Okay. How?
HERC, HERC.info@state.or.us.
What does she put in the subject line to make sure that it gets to you guys?
No, it'll get through.
Well, I know it'll go to Daphne, but will it get to the chronic pain task
force? Chronic pain task force testimony would be good.
Okay. Thank you.
Good morning, I'm Dr. Tricia Wong. I'm a pediatric hematologist at OHSU, where I care for most of our patients with sickle cell anemia, both in pediatric and adults. And so I do implore you to make a special consideration for sickle cell. I've had to spend a lot of time getting appeals, and this is not just for me, but also on behalf of all of the children with inherited disorders, including bone and other disorders that cause pain. And I know these task forces are for adults, are probably intended for adults, but they will have ramifications for us. And just be thoughtful, and I know you are very thoughtful, and so I just ask you to take that into consideration at the end, and being able to account for adults and pediatric patients with inherited disorders that cause pain.
So Dr. Wong, just to clarify for you, sickle cell is a covered condition. It's not one of the ones we're considering.
Okay, I didn't see anything up to that. So thank you very much. There are other inherited conditions, though, that more than sickle cell that also should be considered. And I'm happy to help. I know Dr. Gregg's here too, and we talk a lot. So happy to help however. Thank you.
I'd like to nominate adhesive arachnoiditis. I second that nomination.
Helen Turner,
I'll pass.
BJ Cavnor, Tim Harless, and Vern Sabo.
Good afternoon. For the record, my name is BJ Cavnor. I serve as Executive Director of 104 Chronic Health. We are an Oregon nonprofit organization specializing in working with patients who are living with chronic health conditions. As you know, pain is a comorbidity of many chronic health conditions. To the best of my knowledge, I have not received any funding from anybody who produces an opiate medication or any of the medications which are being considered today. That's my disclosure. I want to talk about something really briefly here, which is messaging. And this should seem like something that doesn't have to be an issue when we're talking about healthcare and healthcare access, but indeed it does. Director Allen's choice in the title of his op-ed in the Wall Street Journal last week, or excuse me, 2 weeks ago. Oregon opiate abuse policy is the right one. We are talking about the difference here between patients and people who are misusing, abusing medications illicitly, and people who are living with chronic health conditions. And that's the difference. Chronic pain patients are not addicts. I want to read one statement, and this is included in the notes to you. And this comes from Dr. Daniel Carr. Stigma, shaming, and shunning continues to befall patients with chronic pain, as do inequities, access to care. Tragically, people with the fewest resources, like Medicaid patients, pain, stability, and effects, minorities, the very old, those with HIV, cancer, I know you're not considering HIV and cancer, or substance abuse. The poor or homeless were marginalized by society. These outsiders have the least access to appropriate pain assessment and treatment. Even prosperous individuals find it hard to find the need for pain prevention and control that's not addressed. Why is appropriate pain treatment so hard to deliver? And I want to, again, say that we are willing as patients and patient advocates to work with you in trying to forward this conversation to find outcomes that benefit everybody. Thank you. I'm happy to answer any questions.
Tim Harless.
Good afternoon. My name is, or is it still good morning? Yeah. Long day already. My name is Tim Harless. I am a chronic pain patient. I'm a veteran. I'm a lot of things. I'm also an advocate for the American Chronic Pain Association. We are looked upon as collaborators by the National Pain Strategy, which means we've worked with the National Pain Strategy a lot. My input on this is I've testified to y'all before. And there's several things I've got to cover, and I'm going to try to do it real fast. So if you have any questions, bear with me, all right? The American Chronic Pain Association is a peer-led support group scenario. It's self-help, okay? This is a mental health, cognitive behavior therapy, or whatever you guys want to call it. But when you get a bunch of people who are in pain, then you'll understand that there's a lot of dynamics that go on here. What I want to emphasize to you all is that the suicide rate goes hand in hand with a lot of other factors, okay? The VA cut me off of my opioids at December. I was in the emergency room twice, 8 hours each time up at the VA, BFD, because you know what they did for me? They did absolutely zero for me. In my advocacy with the American Chronic Pain Association, I've met a lot of people. I'm the first person that they send these people to once they call our office. I can't tell you how many people I've talked to in the last year who are suicidal. I can't tell you how many people are crying because they can't get out of bed. All right? There's a couple things real quick here. And the suicide rates have increased from 7 to 10% since 2014. That's from New England Journal of Medicine's September 11, 2018. Chronic pain is tied to, increased suicide risk, and that's data from 18 states. To put it real short, we're in jeopardy. Whenever you take somebody who's in chronic pain, I like what you were saying, David, is that it is a complex issue when you have all the dynamics of the house. You have your physical, you have your psychological, you have your social, and you have your spiritual. When those 4 legs are broken, you're in trouble. That's what happens to chronic pain patients. We need to take the palliative care approach and help them all out. And I thank you.
Thank you.
For the record, Vern Sabo. I represent the Oregon Chiropractic Association. I'm a doctor of chiropractic in my 38th year of practice, board certified in orthopedics, neurology, and forensic science. My only comments aren't going to be as interesting, they're probably going to be a little boring, but relative to the final recommendations by the task force, and I want to clarify this, I know Ariel knows this, and Kat and Darren, but the comments during the value-based benefits subcommittee when your final recommendations came to us was that chiropractic was not found to be efficacious in these chronic conditions. And that is actually code words for meaning spinal manipulation or osteopathic manipulation. And so part of the issue with that is that's not the only thing that chiropractors do. There's a whole gamut. We have a very broad scope of practice here in Oregon. And physical therapy, physiotherapies, and the modalities, all within our scope and license here to provide. I served on the task force that laid out which interventions, such as manual therapy, therapeutic exercise, therapeutic procedures, neuromuscular re-education. And so those things are within our scope and license to provide. And then I think the other issue is the final recommendation of this task force was also that physical therapy was found to be efficacious. Well, that's a broad brush. You might as well say physical medicine stuff. So I think that needs to be specified a little bit more. And what should I talk about for the next 30 seconds? No.
The weather's nice.
Weather's nice. Thank you.
Let's see. Patrick Starnes, Evelyn Blackburn, and Patty Brennan.
I was reading for Richard Lawmer, so
Oh,
Evelyn
okay.
Blackburn.
Okay.
Unless you want to hear from me again.
Geez, Patrick, your time's up already?
Yeah. My name is Patrick Starnes. I do not own any pharmaceutical stocks, so I have no conflicts. I'm also not involved in this medical stuff that you guys are doing. I'm just simply a cabinet maker from Brownsville who's become an advocate for these legacy chronic pain patients. And what I feel like I bring is a fresh perspective being outside of this situation you guys are in. And I do thank all of you for volunteering and spending your many meetings and the staff for being so good at putting this together and inviting us. But I have to say, I was at the last meeting in August, Ariel, and I was the one that requested that you have 2 seats added to this table, one being a chronic pain legacy patient and maybe one of their care providers. So I was sort of insulted when 2 seats were added to your panel, chronic pain task force, and they were not a chronic pain patient or their provider. So I took that almost as a personal assault because I asked specifically for them to be added 2 seats, and now there's 2 seats added, and it wasn't those people. So that's the outside perspective.
Just to clarify, Dr. Risser is a chronic pain provider. She provides.
Okay, great. 1 seat. All right, good. So half that.
And same with Dr. Greg.
Yeah. So we still need to, because I've been involved in a whole different animal, watershed councils, where all the stakeholders are there, the timber industry, farmers, ranchers, wildlife biologists, and we had to work to get consensus on water restoration, watershed restoration. So you're really missing it, I feel, that if you're not bringing all the stakeholders to the table and to solve this problem. And the last comment is, a free doctor just offered a research project here for patient-centered, compassionate pathway. So, I mean, as just a humble taxpayer and citizen of Oregon, grab that, right? You got a free doctor. That's pretty rare, a free doctor offering to do this kind of research. Let's take a compassionate pathway. Thank you.
Thank you, Patrick.
Yeah.
My name is Patty Brennan. I naturally speak fast anyway, but it's not so much that I'm nervous, it's just my brain does that. I've been a chronic pain patient with fibromyalgia. Dr. Geneva Lipton, who wrote the manuals, contributed, I think, to this board. I've been very stressed over this thought that somebody's going to come in and just tell me I have to taper without any other plan in effect. I know there's medications that I've done alternate therapies for years. I've spent my inheritance on going to clinics and places that provide manual therapies and all these other things, in addition to my opioids. And I continue to do those as best as my finances allow. But I have been on the same opioid medication regime for a decade. And I guess I'm a legacy person, whatever that means. But I function because of those things. I'm a retired nurse. The first thing I learned in nursing, that little old people that fall and break their hips, they die because they can't move around and they get pneumonia and die. But that is the case for everybody. If we don't move, we die. And without my opioids and these other therapies, I would not be moving. I've currently lost body mass just because my knee needs to be done. Getting things authorized. I tried to get injections for my lower back. They denied that. I'm moving down my hip, now my knee, and everything takes so long. This has been going on for a year now, just trying to get somebody to authorize a procedure that would help me with my pain and make me just stable at the dose that I'm at and not add anything else. But it just seems so inappropriate to take people that have got a life that's been stable. I have not increased my opioids or misused them or sold them or whatever they think my contribution is to all these deaths. But really, there's got to be some sanity in all this. Thank you.
Sure.
Okay, thank you. Hi, as you guys know, I'm Evelyn Blackburn. No interest in this other than I'm a chronic pain patient. And I just want to tell you a little bit about myself. I'm 55 and I have severe adhesive arachnoiditis with several other complications. Diabetes I've developed and hypertension as a result of pain. And I have an implanted pain pump. I've gone down in the last 17 months, 62% in my dosage. And to a point, like most people here, I've been a chronic pain patient for 20 years, I should add. So over that period of time, I've done several different things, alternative treatments, just about every one of them that's been paid for by insurance I've tried. My opioids is an important part of my protocol. It's not the only thing I use to treat my pain, but it's an important part of it. I use non-steroidal anti-inflammatories. I did take steroids. I had to stop because it caused the diabetes in me. I have a special diet, an anti-inflammatory diet that's very expensive, but I do it because it benefits me. And I just want you guys to understand that most chronic pain patients that have been chronic pain patients for any period of time have tried all the things that you're suggesting. Yes. And they are important components in treating us. What we're asking you to do is to not take away the one thing that is a part of our protocol that's important to us. Especially I hear a lot of asking for studies, this, studies, that. You're talking about doing this, voting on this as soon as October, correct? Yeah. And you're doing this, as far as I'm concerned, and I studied you like you've studied me. Mine's a double job. I have to understand my side and I have to understand your side because I do care about the opioid overdose epidemic. I care very deeply about it, but I also feel that chronic pain patients are not the cause of that. And so I'm asking you guys to please review evidence that's truly evidence-based and is pertinent to the situation before you make a move like this. I understand why you're doing it. I understand the overprescribing in Oregon and you feel responsible for it. But we are the ones that are going to be affected by this at this point. And so that's all I want to say is just that please take your time in making such an important decision that impacts people, their lives, their families. Okay?
Thank you. So, Ariel, you want to talk about our timeline?
Yeah, so thank you all for coming and speaking to us today. We only have a few minutes left. I wanted to just direct the task force just for a couple of quick minutes to the CCO survey. We did this a couple years ago with the backline implementation, so we're kind of thinking about doing the same type of thing. Are you going to implement acupuncture or cognitive behavioral therapy, et cetera? How are you going to change that? Are you going to implement any prescription controls? How are you going to do that? That type of thing. And we're also going to ask if they have any feedback or responses or learning from implementing all of the backline things that could help inform us moving forward. Are there any specific questions that you think we should ask the CCOs? You got, I believe in your packet there was sort of a rough, what we've kind of put together as a rough draft of the survey.
Can I just add something? I think one of the things that we've learned in terms of the back pain implementation, because we implemented kind of this policy for back pain 2 years ago. So this policy was implemented by HERC for back pain 2 years ago. And I think that what we have learned is that it is very clearly not a black and white policy. And what we learned from this, the prior CCO implementation survey is that there were elements of the guidelines that they planned to implement. There was individual decision making that they planned to do and are continuing to do. And so part of what we're hoping with this survey is understanding what are the elements that would help them in terms of allowing for this individualized decision making, which they are doing and plan to continue to do. And so really kind of understanding that, because this is not, it looks like a black and white policy, and I think that that's a lot of what we've heard from the public, but it's not, and it's not implemented in that way. And so we are hoping that the survey will help us to kind of clarify what are the elements of how we describe this policy that helps just with that individualized decision making and medical review that's going on.
First survey for chronic pain patients.
Another comment on that. The other problem with the back pain when they instituted those is they were so reactionary. It was quite upsetting to see how those were implemented. So I would encourage the CCOs to actually look at things and start reaching out and having discussions early on, because this is not a black and white policy. What we saw with the chronic back pain guidelines is this fact that people knew in advance, but medical systems are so reactionary, all of a sudden patients were just getting a letter saying we're not going to prescribe anymore, without any context, without anything else in there, and that was extremely distressful, to say the least, I think, for everybody involved. So I would hope that there's more discussion going up front. We haven't voted on anything, or actually I don't think we vote, really. So this hasn't been implemented, but anything, communication, as I think we have seen today, is extraordinarily appropriate and important, and I've been just absolutely impressed with all of you. Thank you so much for coming in and providing your stories and perspectives and doing it in such a respectful manner. I really appreciate that.
Thank you for answering questions.
Yeah, am I on?
Yeah, I can help. Okay. So I think it's important to have some kind of question around the referral process and prior authorization process. Utilization management has been a big barrier for patients being able to access some of the physical modalities. It's a little complicated with the 30 combined visits covering different physical modalities. How does that get distributed? What we're seeing is that patients have a very long referral process or a very long prior authorization process, so it takes a long time to be able to get into that first visit for chiropractic or acupuncture, physical therapy. So something consistent among the CCOs, some ways of making sure that there aren't those added barriers, especially when there's a perception by patients that so much is already being taken away. We want to make sure that we're really adding services.
Because one of the priorities of the Oregon State Pain Commission is to help our community change the conversation about pain so that we all understand better how pain works and how we can work together to create an effective treatment plan. I'd like to know from the CCOs what the different organizations have done to promote better understanding of pain among clinicians, and how what outcomes there have been from that in terms of patient-clinician interaction, and maybe also feedback from their patients about the same thing.
I just wanted to add, and piggyback on what Laura said, as a cognitive behavioral therapist, I often only get to see the patients from the CCOs one time. For some reason, there's some sort of loophole, and so some CCOs may give an exception and may give 4 sessions. So the pain experts who do CBT, we should be able to see patients so we can help change some of the other things that could be helpful.
Any other feedback on the CCO survey? Then with that, I apologize for taking up a little bit more of your time than we had asked already. But the sort of important part that staff wants is what direction do you want us to go in? We've heard we're doing a couple of things that we've already kind of moving forward with. We're working with the Evidence-Based Policy Center, with the Pharmacy and Therapeutics Committee. We're going to do the CCO survey. What other information do you want us to get? What direction do you want us to take, if any, in revising the policy and bringing it back to you in December? What specifically can we do to move this forward?
Well, to me, one of the things that I think I can speak about that. It's okay. That has been
actually
one of the things that's been, I think, informative to all of us has been that clarification, the idea of creating a more specific clarification about what a legacy patient is, and then some suggestions about how to frame. If we agree that we want to make that kind of delineation, then some recommendations about what a delineation for a legacy patient might look like. And I think we have some excellent experts who can help us with that, including Dr. Gregg and Dr. Darnell.
Just one last thing. Hello? No, it's working. Go ahead. Oh, okay. I didn't see it. I might have missed it, but is there a way to impart upon CCOs the importance of getting member enrollee feedback into what's working and not for them? If we're having a clinical pain psychologist who has relationship with patients, only able to see them once, it's a setup for failure. If you have an authorization that's only good for X amount of time, when you need multiple intervention to acquire some sort of lasting clinical effect, I think hearing from the enrollees what their experiences are might help us craft better policy overall.
One comment here. I don't want to. Am I on? Can you hear me? Okay. The other thing is what we've kind of touched around and danced around a lot is this word of addiction, and it has been brought up again and again. And we see overlaying terms. I saw this when I was reading all the comments. I went through and printed them all out. And when you hear these words of legitimate pain, I always want to know who has illegitimate pain. And when I hear the word real pain, I'm like, well, who has fake pain? And I get frustrated because sometimes this addiction component completely overshadows the discussion of pain, but maybe that's the wrong approach. Maybe we need to looking at this thing as a joint process here. She left, unfortunately. I wanted to talk to her, but there was someone who has addiction and pain, and that's a patient population we need to be cognizant of, and we need to start actually maybe looking at the literature that's involved with them and bringing it into this, because this is a very tightly overlapped situation, and I don't want to get into this. I'm not an addict and they're an addict and I'm taking this, because everybody deserves compassionate care no matter what your background is. So I would like to pull that in a little bit more, and maybe we can stop being so judgmental in that as well.
I think the dependence and the addiction get confused. Because obviously, I've been on this medication for almost 20 years, so obviously I'm physically dependent upon it. Absolutely. If I don't have it for a couple of days, takes 3 or 4 days or something for me to go into withdrawal. But that's the same case. I mean, my husband, it took him almost 7 months to get off of Cymbalta, which for antidepressant, where he was having more horrible side effects from withdrawal from that than I ever have seen.
And guess what the data is on wean from Cymbalta is?
I don't know.
None. Guess how many people have withdrawal symptoms associated with Cymbalta?
All of them.
Substantial.
Exactly.
So no, absolutely.
So and I think that that's the biggest issue that I have is that people get. I think that there's the huge.
So we're out.
Oh, we're out of time.
Yeah, a huge.
Hey, you can continue that conversation afterwards.
Yeah, I'd be happy
So,
to.
is there any other feedback from the task force for staff? Any other direction, requests for us? So we are meeting again in December.
Can I just, again, that whole education and the whole, I'm to the point now where I need clarification about what we're trying to accomplish moving forward. So I need to understand, are we trying to update guideline note 56, which simply has outdated dates in it, which and guideline note 60, which they need to be updated for those of us that use them every day and implement them every day. The language needs to be updated. That's all we need to do, and we need to get that done. And then I need clarification moving forward. Again, we're trying to add coverage, and I feel like we're starting to spin out of what that was all about. Again, we were trying to add coverage, we weren't taking anything away.
Currently, if the care is provided according to the prioritized list, if someone has chronic pain syndrome or fibromyalgia, they have no access to medication, office visits, any care. So they are not getting anything paid for at all. Which is what would happen. I know that's happening in certain CCOs have been being somewhat hardline. I know that's not what many patients have experienced because of various ways that the CCOs are implementing and doing things. But we are trying to add an evidence-based package of care for this population that has treatments that are effective at improving function and reducing pain, while not providing anything that would cause harms. So,
You're trying to reduce the number of pills to stop overdoses.
so currently there is no medications that theoretically should be paid for by. So if your CCO is following the prioritized list, if you have chronic pain, you have no paid for opioids. We know that is for those conditions. If you have another condition, I believe you mentioned you have several, those may be on a covered line, and they would continue to be on a covered line, and would continue to have access to things.
I was going to say the same thing. I think it would be helpful not just for the commission to remind us of what it is that we're considering, but I think it would also be really helpful for the public to understand what the question is at hand, because I think there's been a number of initiatives and policy actions and national guidelines and our work, all of which have been conflated or rolled up into one body of work. So I think it would be helpful for the public to understand what it is that the task force is asking. And I think you articulated it perfectly, Ariel. Thank you.
And so just is this on, Jason? There it is. So just to kind of go over the timeline for everybody, we actually just started a poll about potential dates in December to meet, to bring back the information you're asking for, to get a report from the Center for Evidence-Based Policy on opioid tapering. So we just kind of started that poll. I know we've got some responses from some of you, but if you haven't responded yet, please, today or tomorrow would be great to hear from you in terms of what dates you're available in December, so we can.
Daphne just resent that email this morning, so it shouldn't be lost, hopefully, in your inbox.
And so, our timeline is this is a potential change to the prioritized list, is a potential significant change in moving some of these conditions into the funded region, and that has to be done as I think it was mentioned before. This biennial review process that we go through every 2 years. And so those decisions about what gets moved up higher on the list have to be ultimately made by HERC by March. So our plan going forward is to bring you back in December, take a look at all of the information we've compiled, and take a look at if you think any revisions need to be made to the proposal that was taken to BBBS in August. Then at that point, we would take it back to BBBS, and at their January meeting, they would have a chance to look at it, a chance to have discussion, because at the last meeting it was just a listening mode, as Ariel said. And then from there would go to HERC either in January or in March. So that's the timeline for us.
Line 1 of the CDC guidelines states that palliative care
so
patients
we're out. We're done with public comment,
If the
and I
Oregon
think
Health Authority follows the
we're
CDC,
adjourning right now.
you would
as
be
a matter of fact.
obligated to.
Thank
So
you.
take-
Thank you for your
all,
time.
adjourned.
Thank you.
No, it's.